thank you very much, every professor to come to NeuroMSA. I like the discussion. Ricardo and Pascal is my friend, also Professor Henders Niemi, and it's possible to discuss with different opinion or different comments. I present two cases. One case is periprocedural rupture of the MCA artery after balloon technique. Is my colleague, but I have a rupture, and you are many cases to rupture of break of aneurysm. First is when you advance the catheter and you remove the guide wire. Sometimes the catheter advance of the fundus of aneurysm, fundus and aneurysm and rupture. Also, the advanced guide is possible to rupture. Also, high pressure coiling, and your accordion sign in the catheter. It's very common, the funnel coiling, or imperinflated balloon. When I use the balloon remodeling technique, I use every time the balloon, assisted balloon to embolize the aneurysm. And two different situations and difficult to discuss is high pressure. When you control, I present one case, I think Pascal with Webb. The high pressure is possible to change the pressure in the neck, and also the indesirable movement of the device. Yeah, this is the case. And Moret described the remodeling technique in 1996. I start at the same time, and it's very good to protect the rupture of intraprocedural rupture of the aneurysm with endovascular technique. And discuss at the beginning when I treated the aneurysm with the balloon in sac, is the technique of Serminenko and Moret with the HEMA. I have some case I have a rupture to the aneurysm, and some discussion is the radial force have the balloon at the neck. This is it's very, to use the balloon technique, you need inflate the balloon very slowly in the brain. It's not at the same of the coronary artery. It's very slow to inflate the balloon every time. This is the remodeling technique. This is the case where I use the balloon, but I don't use the heparinization with the balloon, and I don't use the antiplatelet. This is the, okay, HS. One case, rupture the aneurysm with the coiling. And then use very quickly, you inflate the balloon, and you inflate the balloon here. You push some coils and you stop the bleeding. You have the catheter. What is the pointer here? Here the balloon. Okay, this is a case I like to present now. It's a no bleeding story, 38-year-old woman, family story of hemorrhagic bleeding, a small aneurysm, of course, is treated with a standard technique surgery or a standard coil. This is the work projection. This is the middle cerebral artery. This is M2. and this is the aneurysm. This is the angio, it's very small aneurysm before. The procedure starts in 10:20 in the morning. The coil is placed 20:48, and the coil is too big. When I remove the coil, the patient bled. This is bleeding. And very quickly, my colleague helped me. Please come, because I use inflate the balloon, but at the moment to inflate the balloon, the artery, the middle cerebral artery is ruptured. You have two ruptures, one in the aneurysm and the second one here. I don't know which. This is the time, 11:01. I inflate the balloon. The patient is not anticoagulate. I have a control with another size, with the balloon inflated. I have some endolink contrast in the middle cerebral artery. I remove the balloon and inflate it more proximal to overlap the siphon and the middle cerebral artery, but I don't know, I don't see very well where is the point of rupture of the middle cerebral artery. This is the control, and stay okay. I decide to wait. I perform the CT scanner. I place the extraventricular deprivation, but when balloon is deflated, I have more small endolink. Also spasm, severe spasm. And at this point, I decide to close the spasm and place with reconstruction stenting to reconstruction the middle cerebral artery. This is the control. You are improve the spasm in the middle cerebral artery, stop the flow in this part, improve the spasm in the E1 anterior cerebral artery. But in the later phase, you are some false aneurysm or dissecting or bleeding. I decide it's not good. I wait. In few minutes, the flow stops in this part. I decide finally close the with coiling. Just a minute, very quickly. I decide to put coiling here from here, preserve the anterior coronary artery, finally coiling the middle cerebral artery, This is the contralateral injection. You are some flow, collateral circulation. This is the CT, final CT in the angio suite. No, sorry, and at the 9, going to the surgery to craniectomy. And finally, the patient, 1 month later or a few months later, this is the lesion, sequela. 2 years later, this is the lesion. The patient walked, but have a plagia of the left arm. Is okay. The second case is also MCA asymptomatic aneurysm, 61-year-old. This patient is, I decided to treat with the web. Is my first case. He comes one proctor, and when I discuss, it's similar to the case present Professor Jabbour. You are the middle cerebral artery, one branch, second branch, but you are some angulation. This is the 3D angio reconstruction. And I decided to treat when it's not a complex siphon, but it's not a complex, probably, with the new web. But at the beginning, the device, yes. Every time I have one gate wire support to flow, to push the balloon to protect. This is the balloon technique and the gate wire here. I place the web, and when I remove to open the web, the patient bleed. Very quickly, my colleague going to the compression of the carotid in the neck. This is the major rupture. The web is here. I not remove the web. The web is here. You wait. Later, I decide to navigate with one balloon, inflate the balloon, to replace a little bit the web, but finally, I decide to deploy. This is the balloon. This is the web. Finally, I decide to deploy one Atlas neuroform stent to change the position of the web, because some part of the web is in the middle cerebral artery. There's a final control. This is the CT scan in the angio suite. You have the web here. You are the neuroform, or Atlas is neuroform in this, on reconstruction the vessel. And this is the final control. The patient as well and don't have symptom and total recovery. But the discussion is to present, this is also more image of reconstruction. You have some part of the web still here. And finally, the distal part of the web is not totally open, like a Diana. This is 2 years later, and this is 4 years later. Still, some remnant, but don't change. when in our experience, when the residual neck of the aneurysm don't change in the evolution, I decide not treat it by endovascular treatment because it's stable. This it's possible. This point is to discuss with a point of view of neurosurgery. And this is angio, MR angio. Few years later, is in well, that is and in 7 years later. Okay, thank you for your attention and open the discussion to discuss. Okay, any comment?
Great, let me just get you off the screen share there, Louis.
Okay.
Okay. Okay, comments, questions?
No. Okay.
Well, unfortunately, Pascal and Ricardo had to leave for cases, but anyone else have something they want to weigh in on?
Sir, can I ask a question, sir?
Of course. Hi, Mohammed.
Yes. In case of balloon inflation, which
Yes.
causes rupture of the parent vessel,
Yes.
what should be the cascade of protocol following rupture? What should be the ideal cascade of protocol following rupture?
Is every aneurysm in my department is treated with balloon remodeling technique because is the you place the catheter with the balloon, but not inflate the balloon. When you have a problem to the coiling is the place, or you are a ruptured aneurysm with the coiling, you are the balloon. The balloon helps you to rupture, also help to place the coil. You embolize more fast with the balloon technique, because it's possible to put 1 or 2 or 3 coils at the same time.
Okay.
Luis, can I just make a comment?
Go ahead,
Yes,
Ricardo.
of course.
So one thing you got to be careful is that when you're dealing with this emergency situation, you got to be extra careful with the balloon because again, adrenaline is there, as Juha put on his slide with intraop rupture. Again, you're nervous by the nature of the rupture. You got to be careful with the inflation of the balloon and just take a deep breath and go a bit slower because again, this can happen, and that's one of the most feared things with the balloon that you ruptured. The vessel just made the problem worse, right? When they're trying to fix, but it can happen. So you got to be extra careful because the visualization is worse. So just be extra careful with that maneuver.
Totally agree. I have experienced more than 20 years with balloon remodeling, but this is true. With the novel doctor, you need to be careful with the balloon technique. But at the same of be careful of the neurosurgeon. Be careful when you clip the aneurysm. You need a good learn. It's not the endovascular. Sometimes it's very easy. No. It's dangerous. No. The problem is not
Luis,
yes.
what's your prefer shape of the aneurysm you treated with web? Because this aneurysm is quite shallow and a wide neck. So I don't think it's a very good shape for treating with web. So web is more preferred to treated as a bifurcation aneurysms, but not to the side wall or very wide neck.
Totally agree your comment because this is my first case with web, but he come to help me, the proctor of company. It's a good case. I think it's not a good case, but okay. And I don't use the web because I have other device to treat it. In my critical point of web is you don't occlude it totally the aneurysm. You have 90% or more the remnant neck. And the discussion, the aneurysm rupture of the dome or is rupture of the neck? Or is regrown the neck? How many cases I see in the meeting, the doctor plays a web and then plays a paper line or flow diverter or another, blah, blah, blah. It's my opinion. It's not a good device.
Yeah.
But I have here in this session, and one expert is Pascal Jabbour. I have many experience of the web, but it's my opinion. It's not opinion with another friends.
I think we have a question.
May I have a question for Ricardo?
Go ahead.
Ricardo, are you still there?
Go ahead.
So Ricardo, so do you have some experience in using the web? Ricardo?
Ricardo, maybe.
I'm sorry. I think he went to surgery.
It's too late, no? It's time, no? John?
Yeah, I think we have one question from Joanna Nisula. I'm not sure if she has one or not. Do you have a question, Joanna?
Yes, thank you, John. And thank you for everyone, presenters, outstanding presenters. And I have to say my highest appreciations of this quality. This was my end work of endovascular and skull base, different methods and comparing them, and it was amazing. Thank you so much. I don't have any questions. I'm just really happy to be a part of this. Thank you.
Thank you, Joanna.
Thank you. Thank you, Johanna.
Okay, Louis. So we have another webcast scheduled in a couple of weeks.
Yes, in 2 weeks.
Okay. Any particular theme, or are you going to think about it?
I like to discuss with the professor. Like to come. See, you have. I have some ideas.
Okay.
But I changed the. It's depending. It's not for me. It's depending of the
on the speakers, right. Okay, no problem. Well,
probably I like to discuss to the basilar aneurysm. I think it's a good topic because basilar and the top basilar aneurysm, if you want.
Oh, okay.
Only strict, because you are coiling, you are web, you are flow diverter, you are surgery.
Okay, very good. I'd just like to show the panelists that we have another webcast in an hour. Limbic system and approaches for the temporal lobectomy. And get this word, amygdalohippocamectomy. That's the longest word I've ever seen. Okay, very good. So we'll wrap this up, Louis. Thanks a lot for getting everything together, and I hope you do well in Madrid, one of the finest cities in the world.
And Anand, and Pakistan.
Okay, very good. Thanks all the panelists for coming.
Thank you, everyone.
Okay, thank you. Bye-bye.
Bye-bye.
Thank you.